Wait. Okay. So hello everyone, my name is Meral AlZayer and I'll be your tutor for today. So I'm going to be teaching you guys Hypoxia and VQ mismatch. Okay, so before we start, these are the objectives. And before we start, I just want to say that like if you have questions, please write them in the chat. Like don't unmute yourselves because sometimes it can be like a bit disturbing. I'm going to constantly like look at the chat, and we'll have like checkpoints throughout the lecture where like you guys can ask questions and unmute yourself. Okay. Okay. So first, let's recap. Oh, sorry. First, let's recap. So what is the importance of oxygen? You guys can answer in the chat. Okay. Yeah, okay. So you're right. But why do we need to do that? So exactly, to produce energy. So oxygen is important for many mechanisms, including oxidative phosphorylation for the production of ATP. Now, why do we need ATP? Because if we don't have ATP production, many mechanisms in our body will stop, as we know that ATP is a highly required compound in our body. One important use of ATP is in the sodium potassium ATPase, or like sodium potassium pump. If you can see, can you guys like see my mouse? Okay, if you can see here, this is a cell, and here we have the sodium potassium pump. And this sodium potassium pump requires ATP to like work. And if we don't have ATP, this pump won't work, leading to the accumulation of sodium in the cell. Because what this pump does is that it takes sodium molecules out of the cell here. So if it doesn't work, a lot of sodium molecules will accumulate in the cell, and this will lead, and as we all know, water always follows sodium. So this will lead the cell to swell, resulting in a decrease in the cell function, and many destructions will occur. So some of these functions include absorption and decreased protein production. However, these two steps, or like these steps, are reversible. But if this persists, it can lead to like irreversible damage, destruction, cell lysis, and apoptosis. Is that clear? Okay. So moving on. Let me just get the chat out of the way. Okay. So what's the difference? Okay, by the way, I didn't put click. Was this mentioned in our lecture, or is it no, this is just extra information like that you guys took before, just to like introduce you into the lecture. Okay, I didn't put like the next thing that people do on presentations, but so you guys already saw the answer. But what's the difference between hypoxia and hypoxemia? Hypoxia is low oxygen levels in the tissue, while hypoxemia is low levels of oxygen in blood. Yeah, is that clear? I was supposed to have it then the next so you guys can answer, but do you guys understand the difference between hypoxia and hypoxemia? Okay, so this is very, very important for today's lecture, okay? I'm trying to get, what is it called? Okay. Okay, so first we will start discussing tissue hypoxia, or types of tissue hypoxia. This is when oxygen levels in our oxygen levels are low, like we just mentioned, but the blood oxygen levels are normal, as we just said, because hypoxia is low levels of oxygen in the tissue. Now, there are multiple causes of hypoxia, or low oxygen levels in tissue, and these are, for example, here, the first, we're talking about tissue hypoxia now, okay? These are stagnant hypoxia, anemic hypoxia, and histotoxic hypoxia. Now, what is stagnant hypoxia? Stagnant hypoxia is, for example, when we have arterial stenosis. You guys know what arterial stenosis is, right? Yeah. Okay. When we have arterial stenosis, which means narrowing in the artery, when we narrow the artery, less blood goes to the tissue, which is less perfusion. And this causes there to be a decreased blood supply, which leads to decreased oxygen delivery and hypoxia. Okay, now for anemic hypoxia from the name itself, we know that it has to do with hemoglobin. We know the problem is exactly with hemoglobin. In this case, hemoglobin is reduced, and we know that hemoglobin is the protein that is in our blood, red blood cells that carries oxygen. So if we don't have hemoglobin, if we have reduced levels of hemoglobin, oxygen delivery will decrease because we know that oxygen binds to hemoglobin. And this will lead to hypoxia, okay? As for histotoxic hypoxia, the tissue itself, it can't use the oxygen. So the problem isn't with, like we mentioned before, the hemoglobin or there's an obstruction or something like that. It's a problem with the tissue itself where they can't, like there is oxygen, but the tissue itself cannot take up the oxygen, okay? So when the tissue can't take up oxygen, it cannot take it up to produce ATP. And this is where, like, examples such as enzymatic defects in the mitochondria, and it can't use oxygen to make ATP. An example of this would be cyanide poisoning, which blocks the utilization of oxygen at cellular levels. Okay? This is for tissue hypoxia, which we just discussed the first three, or the three types of tissue hypoxia. Now, we will talk about hypoxemia. Hypoxemia is low blood levels in the blood, or low oxygen levels in the blood, sorry. What should you think of automatically when we say hypoxemia or arterial hypoxia? Do you guys know? Does the PO2 decrease in anemic hypoxia? Yeah, I believe so, if I'm not mistaken. Exactly. Okay. So when we think of hypoxemia, you should think of defective gas exchange in the lungs. And when we have defective gas exchange in the lungs, this leads to low levels of oxygen. Low levels in the oxygen in the arteries. So the PaO2, like Ragda said, it will decrease. So the partial pressure of oxygen in the arterioles will decrease. Okay. So now, when we think of that, we need to think about what can cause this. So, what can cause defective gas exchange? But it says it's normal. You know what? Let me 230 whatever. I'll write it down and I'll get back to you. I'll get back to you later because the doctor didn't even necessarily emphasize on that, so I didn't check it out. But I'll answer you at the end. Okay. Let me write your question down. Okay. So, no, I was talking to 2305686. I don't know their name, but they asked the question. So yeah. Okay. So, moving on to the hypoxemia. What are the causes of hypoxemia? First, we have low inspired oxygen. When we have low inspired oxygen, this means not enough oxygen is being breathed in. Okay. This occurs in situations where we have high altitudes, where the low atmospheric pressure and low partial pressure of oxygen causes decreased alveolar oxygen levels and eventually decreased arterial oxygen levels. Okay, so what this means basically is that when we're in a high altitude, okay, the atmospheric pressure itself, there is low levels of oxygen, min asas, you know what I mean? So we breathe in less oxygen, decreasing the amount of alveolar oxygen, which in turn will decrease the amount of arterial oxygen, right? Why? Because we know that arterial oxygen comes from the alveoli. Okay, we'll discuss this further later on, but this is one of the causes. Is that clear? Okay, so for diffusion limitation. Another reason is the diffusion limitation, okay? And what this is, or first let's discuss what is pulmonary diffusion. Does anyone know? You guys can type it in the chat.
Sorry, can you repeat? What is what?
What is pulmonary diffusion?
Diffusion?
Yes.
It's the diffusion of gases for gas exchange to happen at the alveolar membrane.
Okay. Also, like, is it okay if you like write your answers in chat, because like if a lot of people unmute, it's not gonna be.
Yeah.
Like...
Okay.
Okay. So it is how well the alveoli are delivering oxygen to the blood capillaries. Okay. Simple. So when we have diffusion limitation, that means something is limiting limiting the distribution of that process. You know what I mean? Like when we have diffusion limitation, something is limiting the process of oxygen being delivered from the alveoli to the blood. Okay. And when that happens, this will cause the PO2 of the pulmonary arterial blood. This will be less than the alveolar PO2. Okay, if that makes sense. Okay, does that make sense? Yeah. Okay. So make sure to differentiate between this, yeah. Sorry. Okay. So as for, I was stating another point, I'll state it later. Okay. As for the third reason, we have hypoventilation. Now, what is hypoventilation? Hypoventilation leads to hypoxemia because if we decrease our breathing process, okay, we're taking in less oxygen. And when we take in less oxygen, this decreases the amount of alveolar partial pressure of oxygen, okay, resulting in decreased oxygen levels in the blood, because as we know, it's again explanatory that from if we have decreased alveolar oxygen, we will have eventually decreased what is it called, blood oxygen. Okay. And now make sure to differentiate between this or between like hypoventilation and low inspired oxygen, because in hypoventilation, this can be caused due to like many diseases, okay, such as COPD. I don't think you guys took COPD yet, but this is one of the causes the doctor didn't emphasize on it at all, so you guys don't need to know that. Okay. As for alveolar ventilation perfusion, okay. Yeah, perfect again. Yeah, that's true. Alveolar ventilation perfusion mismatch. Okay, we will discuss this later on in the session, but keep it in mind. And the what is it called? The last reason is right to left shunt. Okay, right to left shunt. This happens when there is mixing of unoxygenated venous blood with oxygenated arterial blood, which causes a decrease in PO2. You guys understand when I say PO2 and PCO2, right? It's just partial pressure of oxygen. Like I don't need to continue saying partial pressure of oxygen all the time. Just I'm going to say PO2. Okay. So when there's a mixing of unoxygenated blood from the venous side with the arterial blood, this causes a decrease in PO2 in the arterial blood, leading to hypoxemia. Okay. Is that clear? Because if we just take blood straight from the venous side and dump it into the arterial side, obviously it will lead to hypoxemia because of the low PO2. Okay. So everything clear? We'll move on. Okay. Okay. So now let's discuss the causes of hypoxemia one by one. So our first cause, or we discussed low inspired PO2, and we explained this in the previous slide. Was there anything unclear about that? Because what I said in this last slide was that's basically what the doctor said. So it's clear? Okay, does anyone have any questions regarding low inspired PO2? Because if not, we'll move on to the second cause. Okay. Perfect. Okay, so now we will talk about diffusion limitation. Okay, I need you guys to focus a bit, okay? So what is diffusion limitation? As we previously discussed, it is when the capillary PO2, or the amount of oxygen in the blood, does not reach the level of alveolar PO2, okay? Let me just remove the chart so I can show you guys properly. Okay. This shows that okay, do you see the red is the PO2 of the arteries, okay? And the blue here is the alveolar PO2, okay? So when, this is the diffusion limitation. Do you see the green? This is the diffusion limitation. And what is it? It's when the arterial PO2 does not reach the alveolar PO2 level, okay? This shows that our arterial PO2 is lower than normal, which means that we have less oxygen than what is required in the blood, okay? Because what's the normal? The normal is for there to be like normal processes going on, and for there to be normal diffusion happening, the arterial PO2 needs to reach the level of the alveolar PO2 for the normal process to occur, or gas exchange, okay? But in diffusion limitation, the arterial PO2 does not reach the alveolar PO2, leading to the to low oxygen levels, okay? And this will lead us to having low oxygen levels in the blood than we need. This results into hypoxemia, because we know if we have low low levels of oxygen in the blood, this gives us hypoxemia, okay? So if you see here the ACDO2, okay, what does this mean? The ACDO2, you can see it here on the right side, where it's here, okay? This is the alveolar and capillary PO2 difference, okay? Now, obviously, in the arterial PO2, it is supposed to reach the alveolar PO2, and it does, okay? And when it does, they would have to have the same value. As I just explained, they'd have to have the same value for the normal process to occur, okay? So if in the normal situation, let's say this red line reaches this blue line, okay? So the arterial PO2 reaches the alveolar PO2, okay? And when this happens, the difference, or the ACDO2, okay, would be 0, right? Because let's say this is 100, okay? And let's say this reaches here, which would also be 100. So 100 minus 100 would be 0, okay? Is that clear on the normal function? Okay. Now, if in this specific case, in this diagram, when we have decreased arterial PO2, okay, so when the red line doesn't reach the blue line, okay, this means that we have decreased the arterial PO2 would be decreased. And why? This is because due to diffusion limitation, okay, such as in this case, okay? And when this occurs, we will have a value difference more than 0, okay? You remember when we just said if the arterial PO2 reaches the alveolar PO2, like 100 minus 100 would be 0. But if it doesn't reach, the value would be, or like the difference in value would be more than 0, okay? For example, let's say this is 100 and this is 80. 100 minus 80 would be like 20. You know what I mean? So it's more than 0. Okay, is that clear? Okay. So now, when did this happen? When did diffusion limitation happen? Again, the doctor didn't explain when this happens. I just thought I would mention it like for clarification purposes, like you guys can like maybe understand it better. This happens in situations such as severe lung damage, infections, pulmonary edema. And one of the most common causes is pulmonary fibrosis. Okay, is that clear? You guys don't need to know that. I just wanted to mention that for like clarification purposes. Do I move on? Okay. So now we will discuss the third cause of hypoxemia, which is hypoventilation. Okay, to understand hypoventilation and to understand how hypoventilation causes hypoxemia, we need to first discuss how normal ventilation occurs. Okay. Again, I believe that this was discussed in previous lectures, but I will go over it because it's important in this lecture, okay? Also, before I explain it, these values here that I'm going to talk about, like the 150, 0, 40, every value like you see on the slide is very important. The doctor mentioned that you guys have to memorize these values, okay? So the normal partial pressure of inspired oxygen, or the PiO2 here, is 150. Is 150, okay? Now, while the, okay, sorry. The normal PiO2 here, which is the inspired oxygen, is 150. While the normal for the normal or for the hypoventilation only, the values, you need to know them for the normal. Okay, you have to know the normal to understand the abnormal. Okay, so the normal and partial pressure of inspired oxygen is 150, and the normal partial pressure of inspired carbon dioxide is 0. Okay, because we don't breathe in any carbon dioxide. Okay. Now, when you inhale and take the oxygen from here, from outside into your lungs, the partial pressure of oxygen in the alveoli, here represented by capital A. Okay, so guys, you should know that capital A is for alveoli, and small a is for arterioles. Okay, so the partial pressure of oxygen in the alveoli is 100, which is decreased from the 150 that we previously had in the inspired air. Okay. And this is due to gas exchange, where oxygen is being taken up by blood and carbon dioxide is being pushed into the alveoli to eventually be exhaled. Therefore, the amount of oxygen in the alveoli decreases, leading to decreased partial pressure in the alveoli compared to the inspired air. Okay, so when we breathe in, oxygen, the inspired partial pressure of oxygen is 150. When we breathe it and take it into the lung, it will be 100. Okay, now why is there a difference? Because when we breathe in, a lot of this air will be distributed into the blood, into like the surrounding tissues and whatever. Okay, and not only that, but here, as you can see, we have carbon dioxide. Okay, so is that clear? Is the reason why we have why there's a difference clear? Okay. Okay, as for the artery, so we discussed the PiO2, like the inspired air, and we discussed what's in the lungs. Now, what is in the arteries here? In the arteries, the arterial pressure of oxygen, as we just mentioned, it's represented by the small a, is decreased to 90, okay, compared to the 100 we previously had in the lungs, okay, or in the alveoli. Now, why is this? One of the reasons is due to the fact that there is mixing of the blood that don't go to the alveoli. So, yes. So, I think, again, the doctor mentioned this before. There are some blood vessels in the lungs that don't go to the alveoli to get oxygenated, and they mix with the oxygenated blood in the arteries, okay? So there's some vessels that don't go to get oxygenated in the alveoli, but they eventually get mixed with the blood vessels that went to get oxygenated in the alveoli. Okay, so when you mix them, this will cause like a dilution effect, you can say, where since you're mixing oxygenated with non-oxygenated, the oxygenated levels will decrease. Okay, if that makes sense. So this, when they mix, as I said, it will dilute and lower the concentration of oxygen in the arterial blood. Okay, this can be demonstrated by the shunts, the Sapician, I can't even pronounce them. Okay, the Sapician shunts and the bronchial veins. They were discussed in previous lectures. Do you guys remember? You guys took them, right? These two shunts. Yeah. Okay, so these two shunts, okay, they're present, and this is one of the reasons. There's another reason what we're going to discuss now. This is one of the reasons why here in the partial pressure of oxygen in the arterioles is less than in the alveolars, okay, or alveoli, sorry. This is because of the shunts that we just discussed. Okay, another reason is due to ventilation perfusion mismatch, which we will discuss later on in the lecture. Okay, is that clear? Can we move on? Okay. So now that you guys understand the normal ventilation process, let's talk about hypoventilation and what happens in hypoventilation and how does it cause hypoxemia. So hypoventilation, from its word, or like the word itself, it means breathing less. So what happens with decreased breathing? The partial pressure of inspired oxygen will remain the same because like the outside air is the same. Does this mean we have diffusion limitations since they are equal, not equal? I didn't understand your question. You mean in the previous slide here? Does this mean we have diffusion limitation in here? Oh, no. This doesn't mean we have diffusion limitation. This is the normal ventilation process. Like in alhamdulillah, in all our bodies, this is the normal process. Like these two shunts, the thespian, whatever they're called, and the bronchial shunts that we just discussed, these are normal in the body. Okay, is that clear? Then what should the number be? Here? The number should be 90 here. This is the normal number. Like this entire slide, this entire process, all these numbers, this is what occurs in the normal, like healthy lung or in the normal body. In diffusion limitation. In diffusion limitation, the number, it depends on the normal like ventilation. We will discuss this later, okay? Like in diffusion limitation, we'll discuss this later. Sorry, I hate typing. No, it's fine. Okay, wait, let me show you. In diffusion limitation, the number, it doesn't matter. You know how we said, for example, the number, it would be 80 because let's say here it's 100 and here it's, 20 because here it's like 80 and here's 100. So 100 minus 80 is 20. You know how we said that? But it can also like be here. So it could be like 100 minus like 60 and it would be like 40. You know, there isn't like a specific number for diffusion limitation. It just depends on the scenario of the patient. And you know how we said like diffusion limitation can be caused by like many diseases, just depends on the patient. Okay, is that clear? Okay, I'm assuming that it's clear since you didn't say anything. But so now that you guys understand the process of the normal ventilation, let's move on to the hypoventilation. As I just said, hypoventilation means we breathe less, okay? And in the inspired air partial pressure, it's normal because the outside air is the same. It was glitching. You guys couldn't hear me? Can you guys hear me? You can hear me? Okay. Okay, since you asked the question, let me repeat it very fast. Okay. Here in diffusion limitation, you asked what would the values be in diffusion limitation. There isn't a specific value in diffusion limitation, okay? It's just depends on the case because we just said that diffusion limitation can be caused due to like many things, okay? And here we just gave the example of it being of the PO2 in the arteries being like let's say 80, okay? And here it's like 100, okay? So 100 minus 80 would be 20, okay? So the ACDO2 here would be 20. But let's say like another case would be where the arterial PO2 it could be here. You know what I mean? Depends on the case. So if it was like 100 and this was like 60, the difference would be 40. You know, so the diffusion limitation, it just depends on the patient's case. You know what I mean? It doesn't like there isn't a specific number. Is that clear? Okay. Okay, yes. Okay, so again, for hypoventilation, the partial pressure of inspired air would be normal, okay? It's 150 because nothing is wrong with the air outside, okay? It's not like, as I said, remember to differentiate this between the first cause, okay, which is low inspired PO2, okay, because in low inspired PO2, the atmospheric PO2 would be low, okay. Best in hypoventilation, the inspired PO2 is normal, okay. It's just the problem is within ourselves, okay. So the PO2, the inspired PO2 is the same. However, with decreased ventilation, we take in less oxygen, okay, decreasing the alveolar partial pressure of oxygen. Okay, so as I said, the outside is normal, okay, but when we breathe in, we take in less oxygen, okay, decreasing the alveolar partial pressure. Recall or compare the 80 here to the 100 we had in the normal, okay. On like the previous slide, okay, remember the normal and the 80 in hypoventilation, and in it's 100 in the normal, okay. So the amount of oxygen decreases and the amount of carbon dioxide increases, okay. Do you see here? In the hypoventilation, the amount of carbon, or the amount of carbon dioxide is 60, and the amount of oxygen is 80. While in the normal, the amount of carbon dioxide is 40. So 40 compared to the 60 here increased. So the amount of carbon dioxide in hypoventilation increased. However, 80 compared to 100, it increased. Okay, it decreased. Sorry. So the partial pressure of oxygen hypoventilation decreases, and the partial pressure of carbon dioxide in hypoventilation increases. Okay, why is this? Because when we breathe in less air, okay, we take in less oxygen. But since we are breathing less, we also exhale less carbon dioxide. So all the carbon dioxide gets like built up or like stacked up in our body. So we take it, so less carbon dioxide gets exhaled. Does that make sense? So this leads to increased carbon dioxide and decreased oxygen. Okay, is that clear? Okay. So again, when looking at the arterial side in hypoventilation, okay, the partial pressure of carbon dioxide should be the same to the alveoli, okay? And so it's 60 here again, and 60 here, okay? And again, only the oxygen partial pressure decreases here compared to here. It's the same thing as here. So remember how in the normal we said that the partial pressure of oxygen decreases in the arterial side compared to alveoli, and the carbon dioxide stays the same. It's the same for hypoventilation. Okay, it's just the values are much lower because the patient is in hypoventilation state, but it's still compared, the arterial side compared to the alveolar side decreases. So here, so in the normal, it was 100 in the alveoli and 90 in the arterioles. In the hypoventilation, it's 80 in the alveoli and 70 in the arterioles. Yeah. Okay. Do you see the difference of 10? Okay, I'm assuming you guys see. Okay. So, but however, the carbon dioxide levels in the arterial side and in the alveoli side stay the same in both. Okay. So here, it's both are 40, and here both are 60. Okay, now you may be asking yourself, why? Why is this? Okay. Okay, you may be asking that if there's shunts, okay, do you see here there's a shunt? Okay, we just said in shunt and VQ mismatch, if there's shunt and VQ mismatch cause decrease in oxygen partial pressure, why does the carbon dioxide partial pressure remain the same and not increase? Okay. Why? Does anyone happen to know, or do I answer? Okay, the simple answer for now, we'll discuss this later, is because shunts and VQ mismatch only affect the oxygen partial pressure and not the carbon dioxide partial pressure. Okay? No, that's not the reason. But the reason is, we'll discuss the reason later. Okay, just now, for now, know that shunting and VQ mismatch only affects the oxygen partial pressure and not the carbon dioxide. Okay, clear? Okay, let's move on. Okay, so this is a checkpoint. Here's where you guys can unmute yourselves and ask question. Is everything clear so far? Okay. And just as a quick recap on this part, quick question to stimulate your guys' mind. What are the 2 reasons that cause a difference in the PaO2 and not? Okay, I think I wrote this question wrong. Okay, but I meant to say what are the 2 reasons that cause a difference in partial pressure of arterial, of oxygen and not carbon dioxide? You guys can answer in the chat. I just mentioned the 2 reasons why it has an effect on oxygen and not carbon dioxide. And I said we will discuss them later. Perfect. Shunting and VQ mismatch. Okay. Okay. So now we'll move on. Does anyone have any other questions other than one of you guys asked me about the anemia question for anemic hypoxia for the PO2? I will answer you at the end of the lecture, okay? But other than that, are there any questions? Okay, perfect. Let's move on to the 4th cause, which is alveolar ventilation perfusion mismatch. Okay, here I need you guys to focus, okay, because this is the part that Dr. Shams focus on the most. Okay, and it's if you guys don't focus and don't follow along, it can be a bit confusing. Okay, so let's bismillah and move on. So as we just said, we will now be discussing the VQ mismatch. Okay, to understand the VQ mismatch, or by the way, V stands for ventilation and Q stands for perfusion. So VQ mismatch is the same thing as ventilation perfusion mismatch. Okay, so to understand ventilation perfusion mismatch, we first have to understand the distribution of ventilation and perfusion in the normal lung. Okay, so this picture is of the normal lung. To understand the normal distribution of ventilation and perfusion, okay, you need to understand that the lung is divided into 3 zones. Okay, zone 1 here, zone 2 here, and zone 3. Okay, if you focus on the left side here, which is the perfusion distribution, I believe I believe that you guys took this before, but as a quick recap, as I just mentioned, perfusion is represented by the Q, and perfusion is higher at the base of the lung. By the way, this is the apex and this is the base. The perfusion is higher at the base of the lung compared to the apex of the lung. Okay, and why is this? You guys took this before, so you guys should know why. So do you guys know why this is? Again, for those who don't know the question, perfusion is, yeah, perfect. It's due to gravity, basically. It's just, yeah, gravity. That's the reason, okay? So this side is clear, right? Now we will move on to the right side, which is ventilation. And ventilation, we know, is represented by V, okay? Ventilation is also higher at the base of the lung compared to the apex, okay? If you recall, this is due to the fact that the upper part of the lung, or the apex, has less compliance, okay? Which means the lung expands less at the top of the lung, or the apex, compared to the bottom or the base of the lung, okay? So the ventilation at the top of the lung is less compared to the bottom, okay? Now the question is, why is the ventilation at the top of the lung less than the bottom? Okay, and why does the top of the lung have less compliance than the bottom? Okay, perfusion compliance is lower at the top, higher volume at the top. Perfect, exactly. You guys already know this, mashallah. Okay, it's I'm going to use the example that Dr. Shams used in the Dr. Shams used in the lecture. Okay. It is because of stretching. Okay. Okay. Let me repeat. Okay, so I need you guys to focus. Okay. The question is, why is there ventilation or why is there compliance less at the top of the lung compared to the bottom of the lung, or apex compared to the base? Okay. This is because of stretching of the lung due to the increase in weight in the upper lung. And when we increase the weight, okay, and when we increase the weight, we increase the stretching. And when there's increase in stretching, we know that as stretching increases, compliance decreases, okay? So let's take a balloon, for example, okay? If I blow a balloon, okay, and I expand it, okay? After I expand the balloon, it will stretch, right? This will decrease the compliance because the more I blow into the balloon, the harder it will get for me to blow more in the balloon, if that makes sense, you know? So this is the example of the compliance or of the stretching, if that makes sense, okay? Is the balloon example clear? Okay. But now I'll talk about Dr. Shams' example, which I think is also great, okay? Dr. Shams used the example of a spring, okay? So this is a spring. Our lungs are like the springs here, okay? If we hold them from the, okay, so if I hold the lung from the top, okay, or like our lungs are hanging in our body, okay? And if I hold the spring from the top, let's say I'm holding it here, okay? It will stretch all the way to the bottom, right? Okay, since it's hanging, so our lungs are hanging in our body like me holding the spring and letting it go, okay? Obviously it gets stretched. The spring gets stretched and our lungs get stretched, okay? But it gets stretched more at the top. Okay, do you see here the space between this one and this one is larger than the space between this one and this one? Do you guys see that? Okay, so the alveoli at the top of the lung, okay, have a higher volume in them, making them stretched out even more. Okay, so the alveoli here, let's take let's pretend the spring is a lung. The alveoli at the top of the lung are stretched out more compared to the bottom of the lungs. Okay, and the more they're stretched out, the less compliant they are. Okay, so if the compliance is lower at the apex, it doesn't let us have wait, let me rephrase that. Okay, if the compliance is lower at the apex, does that let us have higher or lower ventilation? Okay, perfect. So far, you guys know this, okay? It will give us lower ventilation. And why is that? It's because of compliance and due to stretching. Okay, is that clear? Okay, perfect. Okay, now you might be asking yourself, now why is this relevant? Okay, well, you guys have to know this for gas exchange and gas exchange, okay? All of this that we just talked about, you guys have to know this for gas exchange, okay? What's important for gas exchange is the ratio of ventilation to perfusion, okay? So it's not, so we have larger alveolar at the top of the lung. You can say so, it's just they have like higher volume, they're stretched out more, if that makes sense. Okay? Okay. So where was I? Yeah. So you guys need to understand why this is important. What's important here in this slide, okay, is the VQ ratio, okay, or the ventilation to perfusion ratio. This ratio is what's important for gas exchange, okay? For the VQ ratio, you divide the ventilation by the perfusion, obviously. And what does a high VQ ratio indicate? Do you guys know that? High VQ ratio or high ventilation to perfusion ratio. Perfect. Okay. It indicates that the PO2 is high and the PCO2 is low. Okay. Because the person has high ventilation, bringing in enough oxygen and taking out carbon dioxide. Okay. So that's why we have high PO2 and low PCO2. Okay. And in a low VQ ratio, it indicates the opposite, where we have low PO2 and high PCO2. Okay, is that clear? Okay. Now, with that logic in mind, which zone, you know how we just talked about the lung having 3 zones, okay? In which zone of the lung is the VQ ratio high or higher? Perfect, yeah, mashallah, you guys already know half of this information, okay? So for those who don't know, okay, you guys might think that it's the base, okay, because as we know that ventilation and perfusion increases as we go down, okay? But actually the ratio is higher at the top of the lung, okay, or at the apex, because if you divide this arrow, the greatest difference by the way is the way the 2 is up top. Yeah, between the 2 is I read that as by the way. Okay, the greatest difference between the 2 is at the top. Perfect. Okay. And why is the greatest difference at the top? Okay, this is because if you divide the blue arrow here, okay, because we know that VQ ratio is ventilation divided by perfusion, and ventilation is represented by blue, while perfusion is represented by red. Okay, if we divide the first blue arrow by the first red arrow, okay, and do the same at the bottom here. Let's say we divide this by this, and we divide this by this. You will see that the ratio is higher at the top. Okay. Sorry, where was I? Yeah. Okay, why? Because here you can see that the blue arrow at the top is larger than the top red arrow, okay? And so if we divide them, the ratio will be greater than 1. Okay, so let's say here, if we divide this one, obviously this arrow is larger than this arrow, right? If we divide this arrow by this arrow, it will be larger than 1, because obviously if what's on the top is larger than what's on the bottom, if we're talking math, if we divide what's top divided by what's bottom, if the top is larger, it will be the value will be greater than 1. Okay, but the bottom arrow, okay, here it's smaller compared to this one. Okay, so if we divide this one by this one, and do you see how here the length is shorter than this one? If we divide this by this, the value will be less than 1, you know, because this is smaller than this. If we divide something like smaller divided by something bigger, it will the value will be less than 1. Okay. Okay. So if that still doesn't make sense, let's use numbers. Maybe it will make more sense if we use numbers. Okay, let's focus on the top arrow. Let's focus on these, okay? Let's say that this one, the value is 3, okay? And this one, the value is 1. So 3 divided by 1, because we know that VQ ratio is V divided by Q, or ventilation divided by perfusion. 3 divided by 1, the value is 3, right? And if we take the bottom arrow, by the way, I'm giving like these numbers from my mind, you know, just for like clarification purposes, okay? Let's say that the blue arrow is 4 and that the red arrow is 5. Do we have a check point after this? Because I want to mute myself. Yeah, we will. Let me just finish explaining this, and I'll let you unmute yourself, okay? If we divide 4 by 5, it will give us 0.8, okay? So 0.8 is obviously less than 1. So this just proves that VQ ratio is higher at the top of the lung compared to the bottom of the lung. Okay? Does that make sense? Okay, this all proves that the PO2 will be higher at the top of the lung than the bottom if we compare the values, and the PCO2 will be lower at the top of the lung compared to the bottom. Okay, so as a recap, what do we learn from this slide? That ventilation and perfusion increases as we go from the apex to the base. Okay, and yeah, so both ventilation and perfusion increase as we go from the apex to the base. However, perfusion increases a lot more than ventilation does. Do you see how here the line is way longer than here? Okay, like they both increase. Like let's say like this blue arrow compared to this blue arrow is obviously this one is greater than this one, and this red arrow compared to this red arrow, obviously this one is greater than this one. So as we go from the apex to the base, both perfusion and ventilation increase. However, perfusion increases a lot more than ventilation. Do you see how this one is way bigger than this one? And this one is bigger than this one. This, like, the comparison here is way more. Okay, so the perfusion increases way more than ventilation does, making the VQ ratio decrease from top to bottom. Okay, and this ratio, this is what's important for gas exchange. Okay, is that clear? Okay, you guys have to understand this before we move on. Okay, you can, whoever wanted to unmute themselves, you can unmute yourself now before we move on, because it's important.
Basically at the bottom we perfuse more than we ventilate, right?
Yes.
And at the top we ventilate more than we perfuse, right?
Yeah, okay. Yeah.
Okay, and so basically the reason why we have ventilation higher than perfusion is because I think the gases work against the gravity, so we can reach the gases to the apex. Meanwhile, the blood won't sometimes reach the apex. That's why.
Yes, we just discussed the reasons why perfusion is greater at the bottom, and why ventilation is also greater at the bottom. If that makes sense. Did you?
Yeah, I was no, I was just trying to make sure that the information that I have was correct. That's it. Thank you.
Okay. Do you understand so far?
Yes, I understand.
Okay, perfect. So is everyone good enough to move on? Because if like this, for you to understand this entire step, like this is the basis. Okay, you have to understand this very well. Okay. So let's move on. So first, let's recall, what do ventilation and perfusion do? Do you guys know? I mean, like, I think it's self-explanatory from the words, but I'll accept your answers in the chat. Okay, I'll just answer it. None of you are answering. Okay, so ventilation takes oxygen into the lung, and perfusion takes that oxygen from the lung out of the lung and distributes it. Okay, perfusion and transfer of oxygen through the lung below. Perfect. Okay, is that clear? Okay, so if you look on this side, okay, this is normal. Okay, and the normal we discussed earlier in slide 11, which is, I think this is slide 11. Okay, but we discussed earlier. Okay, the normal VQ ratio is 1. Okay, alveolar ventilation is 5 liters per minute, and the what is it called, cardiac output is 5. Okay, so when we divide 5 by 5, it's 1. You know, that's why the normal VQ ratio is 1. Okay, is that clear? So if I take in here 5, you know, and the perfusion is also, the cardiac output is also 5. So 5 divided by 5. So ventilation divided by perfusion, 5 divided by 5 is 1. Okay. For you guys, you guys use 1 as the normal VQ ratio, but in reality, it's actually 0.8, like the actual VQ ratio is 0.8 because the alveolar ventilation is actually 4, not 5. But for the purposes of this lecture, and according to what Dr. Shams said, okay, use the VQ ratio as 1 for it being the normal, okay? Is that clear? Okay. So I think the normal is clear, okay? Now, if we have high VQ ratio, and high VQ ratio is the one in the middle, or the second one. Okay, so focus on this one, okay? Here, high. If we have a high VQ ratio, such as in the second part, this can be either due to the fact that we have increased ventilation here, increased ventilation, or decreased perfusion. Okay. And again, this is just basic maths. I'm not gonna pull a Yazan Masri, okay? But this is basic math. We know that if we have the top as higher than the bottom, it will increase. And if we have the bottom lower than the top, the overall value will increase. You know what I mean? So this is why. So either increased ventilation or decreased perfusion gives us a, I'm going to tell Yazan, it's okay, go tell him. This is why we have a high VQ ratio. Okay. What was I going to say? Yes. Is that clear? Okay. And what does, I don't get the boxes. I'll explain the boxes right now. Okay. Just understand that concept in your head and don't worry about the boxes. I'll explain the boxes right now, okay? What does this mean when we just mentioned before that we have a high like VQ ratio? We just said the high VQ ratio, okay, means that we will have a high PO2 and like low PCO2, right? For the person that said I don't get the boxes, do you remember that? Do you recall? Yeah. Okay. So if you get that part, here you can actually see in the diagram. So this is the normal, okay? And the normal PO2, okay, in the normal partial pressure of oxygen in the arterial and in the alveoli is 100. Do you see that here? The value is 100. This is the normal. Do you see that the value is 100? And again, also like recall that for normal function to occur and for us to not have diffusion limitation, the alveolar partial pressure needs to equal the arterial partial pressure needs to equal the alveolar partial pressure. That's why the value is the same. Okay, and that's why again we have, since the values are the same, again we have normal distribution, normal diffusion, and the entire function is normal, and we have a normal VQ ratio which is 1. Okay, so in the normal, the partial pressure of oxygen is 100. Okay, but we just said in high VQ we will have higher levels of oxygen, okay, or the partial pressure of oxygen will increase, and this is proven by the diagram here. 100, which was normal, is raised to 120. Okay, simple as that. Do you get that? This is basically what the boxes represent. Yeah, okay, perfect. And this is, so now we discussed the normal, we discussed the high VQ. Now what about the low VQ? Okay, again, low VQ, we have a ratio less than 1, again, normal math, okay? This is gonna be due to the fact that either the V, or what's on the top, the ventilation decreases or the perfusion increases, okay? Again, simple math. Do you guys know why the ratio decreases? Or why the ratio is less than 1? Is it clear? Yeah, okay. So as I just mentioned, it can be due to either decreased ventilation or increased perfusion. Also recall again that the lower the ratio, the lower the PO2 levels or the partial pressure of oxygen, and the higher the carbon dioxide levels are, okay? Now, but let's focus on the PO2 levels, okay? Again, going back to the boxes, with low VQ ratio, the partial oxygen pressure will decrease. And this is again clearly demonstrated with the normal being 100, but you can see that in the low VQ, the partial pressure of oxygen dropped like almost to 80. Is that clear? Yeah, okay. So we just talked about partial pressure of oxygen, but what about partial pressure of carbon dioxide? Okay, recall that we just said that with the ventilation, partial pressure of oxygen increases and partial pressure of carbon dioxide decreases, because when we breathe in, we take in like a lot of the oxygen and we take out all the carbon dioxide, okay? But this is only, so this case where the partial pressure of oxygen increases and the partial pressure of carbon dioxide decreases, okay, this is only in the case if the perfusion remains unchanged, okay? This is what we discussed previously. And we said that we will get back, remember when we said like, when I asked you guys why does it only affect the oxygen, not the carbon dioxide? And we said, we'll get back to it later. Now we're getting back to it, okay? So if we increase the ventilation, but the perfusion remains unchanged or remains the same, okay, we will have an increase in oxygen. Okay, so let's say V increases, but Q or perfusion remains the same. So I breathe, I take in more air, but my blood supply still runs the same. My perfusion still runs the same. Okay, what does this mean? This means that no, this does not mean decrease in carbon dioxide. This means that my partial pressure of oxygen will increase. However, my partial pressure of carbon dioxide will remain unchanged because it still gets taken out. Okay? And I'm going to give you guys an example. The situation can be like, let me give you an example and ask your questions later if you guys don't understand, okay? This situation can be, for example, if I place an oxygen mask on myself, okay? I still have normal perfusion. Okay, for example, when I place the oxygen mask on myself, okay, my perfusion, my blood still works the same, right? It didn't change. And now I'm breathing normally and like oxygen on my face, it's still the same, right? My blood perfusion is still the same. Do you guys understand the concept that my blood perfusion remains unchanged? Okay, but what changes? What changes is that I'm taking in more oxygen. If I have an oxygen mask on, I take in more oxygen. So my oxygen levels will increase. However, my carbon dioxide levels will remain unchanged. Why? Because I'm still breathing out that carbon dioxide. There's nothing wrong with my breathing. It's just I'm taking in more oxygen. Do you guys understand why when we increase, do you guys understand so far? If the ventilation increases but the perfusion remains unchanged, we will only have increase in oxygen and not carbon dioxide. Okay, perfect. Okay. Now, since we just discussed the oxygen mask example, let's discuss, let's give you guys an example of exercise, for example, okay? If I'm exercising, I'm breathing in more. You know, when you exercise, you kind of hyperventilate, you breathe in more, okay? So I'm taking in more oxygen. However, my heart is also pumping more as I exercise, you know what I mean? So like, you know, when you exercise, obviously your heart pumps more, okay? So not only will my ventilation increase when I exercise, but my perfusion will also increase, you know, as my cardiac output increases in exercise, okay? So my perfusion will not remain the same when I exercise, it will increase, making my oxygen levels in the body the same, okay? And not increase. You remember how we said in the last scenario, the perfusion remains unchanged when I have like an oxygen mask. When I take in more oxygen and the perfusion is the same, only the oxygen or the levels of partial pressure of oxygen will increase, okay? But in exercise, both ventilation increases, okay? But perfusion also increases, right? So this will lead me to having normal levels of oxygen. Why? Because as soon as I take in this oxygen, like when I'm breathing, like, okay, as soon as I'm exercising, if I'm breathing in more, my cardiac output increases, my perfusion increases. So as soon as I take in this oxygen will be distributed right away. Same change, so it doesn't affect the ratio. Yeah, exactly. You know? So I'm increasing my ventilation, but I'm also increasing my perfusion. So my my ventilation remains, or my partial pressure of oxygen remains unchanged. You know? Does that make sense? Now, why is that? Again, it's because with more perfusion, as soon as I take in more oxygen, it will be taken out of the lungs by the blood. So there is an appropriate increase in both ventilation and cardiac output or perfusion, okay? Does that make sense? Okay, perfect. So moving on to this slide, okay? We now know that the VQ ratio is higher at the apex and lower at the base of the lung, showing us that it is unequally distributed, you know, like higher VQ at the top compared to low VQ at the bottom, okay? Okay, so I want you guys to focus on the left diagram. Look at alveolar region 1, okay? Here we have high ventilation, and this is represented by this large arrow taking in oxygen from outside to the alveoli, okay? Or in this case, it's one alveolus, okay? Here we have high ventilation, but we have low perfusion. Do you see the artery or the artery that goes to this alveoli? It's very thin, okay? So this means that we have high ventilation and low perfusion, okay? What does this give us if we have high ventilation and low perfusion? High PO2, increased PO2, yeah. But does it increase the VQ or does it decrease the VQ ratio? Exactly, it increases the VQ ratio. So in alveolar region 1, we have increase in VQ ratio. Compared to alveolar region 2, we have decreased ventilation. You see the thin arrow, it's decreased ventilation. However, the perfusion, you see the artery is very thick, okay? Or very wide. We have decreased ventilation, but high perfusion. What does this have an effect, or like what will we have as for VQ? Perfect, we will have a decrease or low VQ ratio. Okay, is that clear? So, yes, exactly. As we already mentioned a couple of times before, the higher the VQ ratio, the higher the partial pressure of oxygen, and as mashallah, as you guys already like wrote in the chat, okay? So, but at the end, yeah, what was again? Yeah. So, sorry, I messed up. Let me like repeat. Actually, I didn't mess up any, so I want to like repeat. Okay. You guys just said as we have a high VQ ratio, okay, the higher the partial pressure of oxygen, okay? So the alveolar region 1 will have high partial pressure of oxygen compared to alveolar region 2, okay? If you look at the right diagram here, the alveolar region 1, okay, will have a higher PO2. This is the PO2 scale, okay? We'll have a higher PO2 compared to the alveolar region 2. Okay, is that clear so far? Okay. But however, they still, or the PO2 still has to be between the inspired air. This is the inspired partial pressure of oxygen, and this is the venous partial pressure of oxygen, okay? So it still has to be, these two, alveolar region 1 and 2, still have to be in between the inspired air partial pressure and the venous partial pressure, okay? And why is that? Is because obviously it cannot be higher, like how can the partial pressure of oxygen in the alveolar be higher than the amount that you breathe in, you know, it can't be. And also it cannot be lower than the venous blood because the venous blood is unoxygenated. Is that clear? Do you guys understand why it has to be in between these two? Okay. And do you guys understand why the alveolar region 1 has a higher PO2 than alveolar region 2? Okay. So, in reality, however, our body's PO2 isn't only measured by one alveoli or one alveolus, or one artery, okay? It's a mix. So, at the end, all of these will end up mixing here eventually somewhere, okay? So, the alveolar partial pressure will be somewhere in between these, okay? Because we just said here, or alveolar region 1 will have high partial pressure of oxygen, and alveolar region 2 has low partial pressure of oxygen, but at the end they will end up mixing, right? So when they end up mixing, they will the partial pressure in our body will be somewhere in between, if that makes sense, okay? It will be somewhere in between partial pressure of alveolar 1 and 2. However, but it will be closer to 1. Okay? Why? It's because that's where most of the gas comes from. Okay? Do you see how here this is partial pressure of alveolar 1, and here's partial pressure of alveolar 2? Okay, but after they mix, okay, it will be, do you see the blue dot? It will be closer to alveolar region 1. And why is this? This is because the majority of the oxygen obviously comes from, or the majority of the gas obviously comes from the first alveolar, you know? Alveolus. Okay, the same goes for arterial partial pressure of oxygen, okay? But in this case, it will be closer to the to this dot. Do you see the red dot? It's closer to the second region, or the alveolar region 2, okay? Now, why is this? It's because it has more perfusion. Okay. Do you guys, my laptop's gonna die. Wait, let me guys put my laptop in the charger. Okay. Can you, yeah, let me repeat. Okay. So, here, do you guys understand the concept of the partial pressure or of oxygen in the first region, or alveolar 1 region, is higher than the second region? You guys understand that, right? Okay. Now, but our body isn't only measured on one alveolus, you know? Our body's entire partial pressure is a mix of all the alveoli in our body, right? Is that clear so far? Yeah, okay. So if we mix, let's focus on the alveoli, okay? If we mix all the gases or the partial pressure of oxygen in our alveoli, okay? If we mix them all, okay? In this case, let's say our body has alveolar 1 region, alveolar 2 region, okay? If we mix them both, obviously the partial pressure of oxygen will be in between them. صح? It cannot be higher than 1, but it also cannot be lower than 2. Why? Why can't it be higher than 1? Because there's 2 that pulls it down, because the partial pressure of oxygen in 2 is lower than 1. Okay, so it will be somewhere in between. Does that make sense? Why it will be somewhere in between? Because they're mixing. Okay. You guys now understand it will be somewhere in between. The partial pressure of oxygen in the alveoli will be between alveolar region 1 and alveolar region 2. However, it will be closer to alveolar region 1. Do you see the blue dot? This is represented as the mix. Okay, this is the mix. It will be closer to alveolar region 1. Okay, why? Because the majority of the partial pressure of the alveolar comes from 1. So it's clearly, it will be closer to 1. You know what I mean? Like, let's say this one has 90, okay, and this one has 10, okay? This will have like 85. Why? Because the 10 pulls it down shway, because yani, it's not as ventilated as 1. 2 isn't as ventilated as 1, okay? But it's still closer to 90, you know? Let's say this is 85, okay? This 85 will still be closer to the 90 than to the 10, because the majority of the gas comes from alveolar region 1, which is 90. Do you guys understand why the blue dot is closer to alveolar region 1 partial pressure of oxygen than alveolar region 2? Okay. Are you all clear on that? Okay, perfect. Now the second region just dilutes. Yeah, the second region just dilutes it a bit. Perfect. Okay. So it won't be like exactly like it. It will be a bit less. Okay. That's why it's closer to it. It will be only a bit less than it, but it's closer to it. Okay. This is the same concept for the arterial partial pressure. Okay. Now, the arterial partial pressure of what is it called? Of the second one is higher than the first one. The in region 2 is higher than the region 1, right? Because there's more perfusion in region 2 than region 1. Is that clear so far? Okay. At the end, just like the alveoli, the arterial, like obviously the blood will mix eventually, right? But again, it will mix, and the less perfused will mix with the more perfused, okay? And it will, do you see the red dot? It will be closer to the second alveolus. Why? Because alveolus is more perfused than alveolus 2 is more perfused than alveolus 1. It's the same concept as the ventilation here. Not, yeah, sorry, I meant the artery here, by the way, the perfusion. Let me repeat, okay? This in the arteries, okay, it's the exact same concept as the alveolus, okay? It just happens to be that in the second alveolus is more perfused than this first alveolus, okay? So after mixing, the value will be lower than the second alveolus, but it still would be closer to the second alveolus than the first alveolus. Why? Because the second alveolus is more perfused than the first. It's the same concept as, I keep on saying alveolus, I mean arterial. It's the same concept as the alveolus. Is that clear? Okay, is it clear for everyone else? Okay, perfect. Okay, now recall that the alveolar end capillary pressure, or no, recall that the alveolar end capillary PO2 difference here, alveolar end capillary PO2 difference, okay, was we mentioned it previously in slide 9. Do you guys remember when I talked about the diffusion limitation and I explained the alveolar end capillary partial pressure of oxygen difference? Yeah, okay. We said that the partial pressure of the artery has to reach the alveolar partial pressure of the alveoli, yeah, of the alveoli, obviously, to for there not to be hypoxia. Do you guys remember that? Okay. So in this slide, do you see this difference? And unfortunately, the partial pressure of oxygen in the arterial doesn't reach the alveolar partial pressure of oxygen, okay? And what does it mean when it doesn't reach? Here we have unequal distribution of ventilation and perfusion. This is also known as VQ mismatch, okay? And this will lead to hypoxia. Here we have hypoxia. On top of that, like, and what's the cause of the hypoxia in here? We will have unequal distribution of ventilation and perfusion. All of this, we just explained why we'll have unequal distribution of ventilation and perfusion. This is what we call VQ mismatch. So this entire slide explains VQ mismatch. Is that clear? Okay, perfect. If you guys understand this, inshallah, you guys will be good for the exam because this is like, you know. But okay, in a normal lung, this VQ mismatch is present because obviously not all our alveoli are ventilated the same, nor are they all perfused the same, you know. But however, this normal mismatch stays in a normal range between 3 to 10, okay, millimeters mercury, okay. But if the value is higher than 10, this is when the mismatch becomes problematic. And this is when we know that we have a problem, okay? This indicates that the VQ mismatch is so severe that it leads to hypoxia, okay? This happens in situations such as, like in numerous diseases such as pulmonary embolism, asthma, COPD, bronchiectasis, cystic fibrosis, interstitial lung disease, and pulmonary hypertension, but you guys don't need to know these, okay? I just included them for clarification. But, okay, so what I just said, okay, increased mismatch shows in lung emphysema, exactly. It's not only lung emphysema, but lung emphysema does cause VQ mismatch, okay? So, what I just explained is that in our normal body function, obviously, not all alveoli work the same, nor not all our capillaries perfuse the same, صح? Is that clear? So it's normal to have this kind of mismatch in our normal body, but the normal range of a mismatch is 3 to 10. If it's not necessarily considered a VQ mismatch here. It's just this is the normal body, okay? When is the VQ mismatch considered like severe and actually problematic? When the difference is more than 10, okay? Quick recap of the slide. Okay. What do you want me to recap? Because I kind of like went on 3 things. I talked about the alveolar 1 and 2, and I talked about the difference here. And I talked about the VQ mismatch, like all of it. What do you want me to discuss? Okay. To be honest, it's the hardest slide for me. Okay, yes, you're right. This slide is actually very hard to understand. Okay, and if you understand this, like it will, like the majority of the exam, in my opinion, I think will come from here. Okay, so let me first start by talking about alveolar region 1 and 2. Okay, in alveolar region 1, there's more perfusion, okay, and less, there's more ventilation, sorry, and less perfusion, okay, giving us a high VQ ratio, okay. Again, it's hyperventilated, it will have a high VQ ratio, okay, here. So the high ventilation, high VQ ratio indicates that the partial pressure of oxygen will be higher than normal, okay, or high, okay. While in alveolar region 2, we have low ventilation and high perfusion. What does this mean? It means low VQ ratio. And what did we say with low VQ ratio? The partial pressure of oxygen will be low. So do you see the dots here and here? This is what we just mentioned. Is that clear for you so far? Is it the same as diffusion limitation? Yes, it's similar to diffusion limitation. Like one of the causes of diffusion limitation can be, like I just said, many diseases. It's not the exact same as diffusion limitation. It's just like a similar issue. You know what I mean? Like here, there's like there are many causes that cause this. It's not necessarily like an obstruction, like diffusion limitation, for example. Is that clear? Okay, I'll move on. Okay, so when we have these 2 dots, okay, the obviously we just mentioned the partial pressure of alveolar region 1 is higher than partial pressure of alveolar region 2. However, they will end up mixing, okay? Obviously, because you don't only breathe from one alveolus, okay? All your alveoli will end up mixing, okay? And when we mix alveolar region 1 and 2, the body's partial pressure of oxygen will be in the middle of them, okay? Because obviously you cannot be more ventilated than the most ventilated alveoli and alveolus, and you cannot be less ventilated than the least ventilated alveolus, okay? So it will be somewhere in between. However, it will be closer to the most ventilated alveoli, okay? And it will decrease it will decrease شوي because there's mixing, but the decrease won't be so severe that يعني it will be closer to the lower ventilated alveoli. Why? Because you still have the higher ventilated alveoli. You know, it will be closer to the higher one. Does that make sense? That's why the blue dot is closer to the arterial region 1. Is it clear so far? Okay. Now, we just discussed the partial pressure of oxygen in the alveoli. Now let's talk about the partial pressure of oxygen in the arterioles. Okay, arteries. Okay, so we just said that the alveolar region 1 is less perfused. Here, do you see the thin artery? It's less perfused than alveolar region 2. Okay, what does this mean? Again, here, obviously, this doesn't change. The partial pressure of them doesn't change. What this means, it's just exact thing as I just talked about, as I just mentioned with the alveolar partial pressure, but it will just be reversed. Why is it reversed in this case? Because in this specific case, it's reversed because the alveolar region 2 is more perfused than alveolar region 1. Therefore, the red dot, or the partial pressure of the oxygen in our arteries in our entire body, will be closer to the more perfused one, because as we said, after mixing, it will decrease, but it won't decrease too severe to the point where it reaches the lowest one. It will, our body is still overall ventilated, so it will be closer to the most ventilated one. Does that make sense? Okay. And this is why we have the blue dot here and the red dot here. However, now we need to understand, do we have hypoxemia or we don't have hypoxemia? What's the point of the cross? The cross is just explaining, it's just showing you that you need to compare arterial alveolar region 1 with 2 to get this dot. It's just basically what I just explained now. Does that make sense? Are you clear with what I just said? Because if you understand what I just said, you understand the slide. Okay. So now we need to know, now we know we have some type of mismatch, okay? Or whatever we just explained, okay? Now we need to know, we got our overall, our entire body. Do you see these dots? This is the partial pressure of oxygen arteries in all our body, and this is in the alveoli. Okay. Now, do we have hypoxemia? Do we not have hypoxemia? What determines whether we have hypoxemia or not? We mentioned this previously. Here, one of the things we can determine hypoxemia is through this alveolar arterial difference, right? What did we say? For us to not have hypoxemia, our arterial, let me refer to the slide. Let me go back to the slide. Do you guys remember the slide? Here, diffusion limitation, it's similar to what we just described. Remember how we said that this partial pressure of this artery needs to reach the alveolar partial pressure for us to not have hypoxemia? Do you guys remember this? Okay. We just said that the arterial partial pressure needs to reach the alveolar partial pressure for us to not have hypoxemia. However, as you can see, these dots, they don't equal each other. The arterial partial pressure is lower than the alveolar partial pressure. Therefore, in this specific case, we will have hypoxemia. Okay. And what is the cause of this hypoxemia? Is what we what we just explained. This is the reason why we have hypoxemia, and this is called VQ mismatch. Why is it VQ mismatch? Because here the VQ is high and here the VQ is low. Does that make sense? Okay, alhamdulillah, perfect. I'm glad you guys understood this concept. Okay, And the last thing I talked about on this slide is the fact that in our body, we have this normal VQ mismatch, but the value is between 3 to 10. And if the VQ mismatch is higher than 10, this is when it's a serious problem. This is when it's actually called like a VQ mismatch, like cause of hypoxemia. When the value is greater than 10 and it's like caused by many diseases such as cystic fibrosis, like lung fibrosis, like COPD, and like edema, like embolism, asthma, all these causes. You don't need to know this. Is that clear? And no, that's fine. Don't apologize for making me explain. That's why I'm here. I hope you guys understand this concept. Everything clear so we can move on? Perfect. Okay. This slide I got from Boards and Beyonds. Okay. So this slide is only for further understanding. Okay, I will talk about pulmonary edema and how it can cause hypoxia or hypoxemia due to VQ mismatch. Okay, pulmonary edema is a condition where we have liquid in alveolus. Okay, and this liquid blocks the ventilation of the alveolus, which decreases the VQ ratio. Okay, you see here, this is blood. This is liquid accumulation in the alveolus. What will happen if we have liquid accumulation in the alveolus, also known as pulmonary edema? We will have less ventilation. This alveolus won't be able to ventilate properly, obviously, because there's like the fluid is obstructing that. So when we have less ventilation, what does this mean? Our VQ ratio will be less than 1. Okay, as you can see. Is that clear so far? Okay, on the right side here, and obviously, by the way, what happens when we have less ventilation? Our arteries don't get perfused as much because we are giving them less oxygen. Okay, but if you look at this right side is normal. Okay, we have a normal alveolus where the VQ ratio is normal, which is 1. Okay, the difference between the alveoli here, do you remember how we just said it's always the mismatch? It's the difference between them, because our body isn't only ventilated by one alveolus, it's ventilated by many. Okay, so when we take these two, they're going to mix eventually. Okay, so the difference between these two alveoli gives us a VQ ratio mismatch. Okay, why do we have a VQ ratio mismatch here, which will give us hypoxemia? It's because due to less ventilation on the left side, it will give the arterial system, okay, the arterial blood system, blood that's not well oxygenated, okay, and the right side will give us oxygenated blood. So if this gives us non-oxygenated blood and this gives us oxygenated blood, our total will be blood that's not fully like oxygenated to the normal level where we want it to be like oxygenated at, you know what I mean? So this will cause hypoxemia. Okay, why will we have hypoxemia? Because as you can tell here, our oxygen levels are lower than normal, are lower than what our body requires. Does that make sense? Okay, perfect. I'm glad you guys are understanding this. Okay, now this is okay. I know guys, like you guys are tired. Do you guys want actually no, I'm gonna finish the VQ mismatch and then I'll give you like a 3-minute break, okay? Because we're almost done. Is that okay with you guys? Okay. So for this slide, okay, let's focus on the diagram on the left. Okay, here. This is where we have blood flow or perfusion. You see, our artery is full, it's red, it has blood, okay? However, we don't have ventilation, okay? So the blood comes from the venous side to the arterial side, okay? And it doesn't get oxygenated. We know that the blood in the venous side is, do we get solved questions? Yes, I have practice questions at the end. You guys are gonna solve, okay? So we know that I know you guys are like tired, but just like bear with me, like just you know, it's fine. We're almost done. And if you guys understand this, like it's like I remember like it was a hard lecture for me to understand first year. So if you guys understand and understand this, like, you know, it's amazing that you guys understand this, you know. Anywho, so you're not tired? Okay, that's perfect. Okay. Anyhow, if you have, okay, here we have normal perfusion, okay, but our ventilation is like obstructed. We don't have ventilation, and we know that blood is like it goes from the venous side to the arterial side, okay. However, if our venous blood goes to the arterial side without it getting ventilated, like our venous side is already unoxygenated, and it goes to the right side without it even getting oxygenated, so it will be unoxygenated. The arterial side will have blood that's not unoxygenated. Why? Because it's not getting ventilated properly. Okay, so this is considered to be a right to left shunt. Why is it a right to left shunt? Right, because our right side of the body is known to have like not our right side of the body, like our right side of the heart is known to have like venous blood or unoxygenated blood, and it will go to our lungs and it will get oxygenated, you know. So the left side of the heart is considered to have like oxygenated blood. That's why it's called right to left shunt. Okay, so when we don't have ventilation, our V would be 0, and 0 divided by anything is, what's 0 divided by anything? 0. Perfectly. Again, I'm not as in muscle. Okay, so 0 divided by anything is 0. Okay, this is why when we don't have ventilation, our VQ ratio will be 0, because with no ventilation, V is 0. 0 divided by anything, حتى لو perfusion كان 100, it will be 0. Okay, do you guys understand the left side, this diagram, the right to left shunts? Okay, now let's move on to the right side of the diagram. Okay, and the right side of the diagram, as you can see, we have ventilation. The blue is getting ventilated, like our alveolus is blue, so it's getting ventilated. However, we have a block in our blood supply. This could be, for example, due to an embolus that blocks our artery, okay, and block our blood supply. Okay, when this occurs, when we have ventilation, however, and we don't have blood supply, this is called as dead space. I believe, again, that you guys took this before in a previous lecture, if I'm not mistaken. But for like explanation, dead space is part of the lung that has ventilation but does not have perfusion. Okay, so it cannot participate in gas exchange because it lacks blood supply. Okay, so when we don't have perfusion, our Q becomes 0. Okay, and when we divide anything by 0, what will our ratio be? Perfect, infinity. Okay, so anything divided by 0, which is our Q, it will be infinity. Okay, does that make sense? Do you guys understand right to left shunt and dead space? Okay, perfect. Then you can move on. Okay, so recall when we mentioned that VQ mismatch only affects oxygen and not carbon dioxide. Do you guys remember when I said that? Now, why is the reason? Why does VQ mismatch only affect oxygen, not carbon dioxide? Okay, it's because of this dissociation curve. Remember when we said we'll discuss it later? We are now discussing it later. The reason that VQ mismatch and shunts and yeah, I think it's VQ mismatch, shunts, and another thing, I forgot about this, I will mention it later. It doesn't affect carbon dioxide and it only affects oxygen is because of this dissociation curve. Okay, as diffusion limitation. What do you mean by diffusion limitation? Oh, the third thing. Yes, yeah, you're right. Diffusion limitation. Yes. Okay. So as you can see here, we plotted the concentration against the partial pressure of oxygen. Okay. And let's take an example where our partial pressure starts at 100. Okay, let's when our partial pressure starts at 100. Okay, I'll be using the example. Okay, I'll be using again the example of the doctor because the doctor, like, you understand what the doctor said in class. I think it's best because obviously, like, you guys need to understand what the doctor said. So the doctor used the example of our partial pressure being starting at 100, okay? By the time our blood reaches our legs, okay? So our blood gets pumped, gets oxygenated, and it gets distributed to our legs, okay? By the time our blood reaches our legs, okay, where was I? Yeah, okay. Just our legs, okay. Yeah, 50 here. Do you see here? Okay, 50 milliliters per liters, okay, of oxygen gets distributed. Okay, obviously because if I'm going if I'm distributing the blood from all the way up from my heart all the way to the body, obviously as I go down, the obviously there will be distribution of blood supply, you know what I mean? So 50, let's say 50 of our oxygen will be lost, 50 milliliters per liters, okay? Where will it be lost? It will be taken up by the tissue, okay? This will lead our partial pressure to decrease by 60 millimeter mercury, okay? Let's say here, by the time we start at 100, or this is 100, okay? Let's say we start at 100. It's around 200, but the doctor said 100, so we'll say 100. Let's say we start at 100. By the time we pump our blood and it goes all the way down to our legs, okay, we lose 50% of the 50 milliliters per liter of the concentration of oxygen, okay? And when we lose this 50, this will lead to a loss of partial pressure of oxygen in our body from 100 all the way to 40. So this will lead us to a loss of 60 millimeters of mercury. Okay, is that clear? So what does this mean? You can tell now, so as little as 50 milliliters per liter decrease in our oxygen concentration, our partial pressure of oxygen will decrease so much. So little as 50, do you see this line is very small? Where is it? This line is very small. This will cause us a decrease of 60, which is so much in our oxygen dissociation curve, okay? This shows that VQ mismatch or any small change will cause a lot on the partial pressure of oxygen. However, if you take the dissociation curve of the carbon dioxide, you know how we said that by the time the blood reaches our legs, we will lose 50 milliliters per liters of concentration of our oxygen. It will get taken up by the tissues. Okay, what does oxygen get exchanged for though? It gets exchanged with carbon dioxide. So 50 milliliters per liter of carbon dioxide gets added, okay, or gets put in our blood because it's just normal gas exchange. The body takes oxygen and releases carbon dioxide, okay? This, however, only increases our carbon dioxide partial pressure with 5 millimeters of mercury, okay? Changing it from 45, where it originally was, you guys see where it was 45, changes from 45 to 40, okay? This literally shows you guys, okay, compare this 5 millimeters of mercury with this 60 millimeters of mercury of partial pressure of oxygen. Compare it with the 5 partial pressure of carbon dioxide, okay? Obviously, the 60 is way larger than the 5, okay? The difference in oxygen compared to carbon dioxide is a lot more, okay? And this is why any minimal change in carbon dioxide will not have an effect, okay? And this is why VQ mismatch only affects oxygen and not carbon dioxide. Okay, this is because the carbon dioxide dissociation curve is very steep. It's very steep. Okay, is that clear? Why VQ mismatch and diffusion limitation and what else was I going to say? Diffusion limitation, VQ mismatch. Forgot the third reason that I just mentioned. We'll get back to it later. But these three, shunting, VQ mismatch, and diffusion limitation affect partial pressure of oxygen, not carbon dioxide. Is that clear? When we lose 50 carbon dioxide concentration, we lose 5. No, here. When we lose 50 of the concentration of what is it called? Of oxygen. You know how we said as the body pumps blood من فوق لتحت, loses oxygen concentration because it gets perfused in the tissue. So that little of 50 milliliters per liter, what like oxygen, and when we take out oxygen, carbon dioxide gets put into the blood. You know what I mean? Like because it gets because of the gas exchange. So as little as 50 milliliters per, or like again 50, like you can round 43 to 50, you know, we can compare. Okay, as little as 43 or 50 milliliters per liter change in concentration of oxygen. Here we will only have a partial pressure change of 5 millimeters of mercury in the carbon dioxide dissociation curve. However, in the partial pressure of oxygen dissociation curve, the change of partial pressure will be 60. Does that make sense? So the carbon dioxide partial pressure will only change. What's RQ? RQ is just the ratio, like we just compared here 35. You don't need to know RQ. RQ is just they're comparing the 43, which is in reality like you know how I said 50 here, 50 milliliter per mercury, 50 milliliter per liter. I used 50 milliliter per liter here, just for like comparison purposes. You guys don't need to know this, but here they took this 43 divided up by this 50. Okay, is it clear why these 3 reasons only affect oxygen and not carbon dioxide? Okay, perfect. Now we can come to our last reason of or last cause of hypoxemia, which is right to left venous shunt. Okay, so this should be simple. Okay, because like we like kind of also like went over it before. In right to left venous and right to left shunts. Okay, sorry, where was I? Okay, in right to left shunts, the venous blood does not go to the alveoli to get oxygenated. Okay, it automatically goes to the and mixes with the artery. Okay, this causes arterial blood to not be oxygenated, and this causes hypoxemia. Okay, why does it cause hypoxemia? Because the value of the blood, of the arterial blood, will not have oxygenated blood because we're shunting the venous blood على طول into the arterial blood. Okay, this can occur in conditions such as ventral septal defect. Simple as that. You don't need to know ventral septal defect. Is this pathological? Yeah, it's pathological. Because like conditions cause this. Like obviously hypoxemia, you don't get hypoxemia like from normal things. Like obviously there has to be a reason why you get hypoxemia. And we mentioned 5 reasons, and obviously all these 5 reasons, there's like a pathology underlying it. For example, just mentioned like cystic fibrosis, edema, embolism, like ventral septal defect. Okay, is that clear? Okay. So this is a very, very, very important slide. Also, I just wanted to mention that I attended like your guys' lecture today to prepare for this PAL session. So I need you guys to focus with me on this slide, and because it's very important. Like it basically summarizes everything, like all the causes of hypoxemia. Okay. So the slide's very important, so focus on it. So the question now is, if we have these 5 causes of hypoxemia, how do we differentiate between these 5 causes? Okay, so we have obviously all of them are hypoxemia. So the partial pressure of oxygen in the arteries and all will be decreased. And these are like VQ mismatch, right to left shunt, diffusion limitation, diffusion problems, hypoventilation, and low inspired oxygen or low inspired air. Okay, all of them will have a low partial pressure of oxygen in arteries, obviously, and that's what hypoxemia means. Now, how do we differentiate between them? First we have to look at the carbon dioxide. Okay, the partial pressure of carbon dioxide in the arteries, okay? If we have high partial pressure of carbon dioxide in the arteries, okay, we automatically can conclude that the cause is hypoventilation, okay? Now, why? Because in hypoventilation, since we breathe, since we're breathing less, okay, we will have decreased intake of oxygen levels, okay, and increased levels of carbon dioxide in our body. Why? Because we are breathing less, so we take in less oxygen and we exhale less carbon dioxide. So if we take in less oxygen, our partial pressure of oxygen will be decreased. And if we exhale less carbon dioxide, our partial pressure of carbon dioxide will increase. Okay? So, is that clear on our first differential? Okay. Now, this is if we have high carbon dioxide. Now, what about if we have low carbon dioxide? Okay, if we have low carbon dioxide, so both the partial pressure of oxygen and carbon dioxide are low, we can conclude that the cause of the hypoxemia is high altitude or low inspired air. Okay, is low partial pressure of inspired air, such as in high altitudes. Why? Because we breathe in less, and we don't even have enough oxygen in our air to breathe, if that makes sense. We're trying to breathe more to take in more oxygen, and the more we breathe, the more carbon dioxide we exhale. This is why we have a low carbon dioxide. Okay, is that clear? Okay, so we discussed how to differentiate between hypoventilation and low partial pressure of inspired air, okay? But we still have 3 remaining causes that we need to differentiate. Like, how can we differentiate between them? Why do we need to differentiate between the other 3 causes? Because the rest of them all have normal partial pressure of carbon dioxide, okay? Not only do they all have normal partial pressure of carbon dioxide, but they all have the unchanged difference here, and they all have increase in the difference here, okay? How do we differentiate between these 3 causes, which are high or like VQ mismatch, right to left shunt, and diffusion problem? We can differentiate between them by giving 100% oxygen to the patient. So let's say a patient presents with hypoxemia, and we already excluded hypoventilation and what is it called, and low partial pressure of inspired air, because of the normal levels because the partial pressure of carbon dioxide appeared normal. We have 3 differentials, which are VQ mismatch, right to left shunt, and diffusion problem. How do we differentiate between them? We give the patient 100% oxygen, okay? If we give the patient 100% oxygen and there's no change, like the arterial partial pressure did not increase, here it did not increase, we can automatically conclude that the reason of hypoxemia is increased right to left shunt, okay? How can we conclude that? Because the blood in the first place does not get ventilated, okay? So as it gets shunted, it's not even ventilated in the venous side, okay? And it's not even gonna get ventilated because it gets shunted. It doesn't even pass through the pulmonary arteries, okay? So if it gets shunted, our partial pressure in the arteries will not increase. The partial pressure of oxygen will not increase. So if we have normal carbon dioxide and we don't have an increase in partial pressure of oxygen, we automatically can conclude that it's right to left shunt. Is that clear? Okay. Now this gives us a remaining of 2 differentials. We need to differentiate between VQ mismatch and diffusion problem. How do we differentiate between them? You guys, I need someone to answer in the chat because I attended your guys' lecture today and doctor mentioned it clearly in the lecture today. How can we differentiate between VQ mismatch and diffusion problems? Like, let's say we gave a person 100% oxygen and the partial pressure of oxygen in the arteries did increase. See here, it's a yes and a yes. Okay. How do we differentiate between them? Perfect. Exactly, guys. I'm proud of you. We differentiate between them by what is it called? Oh, where was I? Yeah, we differentiate between them by the carbon monoxide diffusing capacity. Okay. But before that, if it's low, exactly. If we calculate the carbon dioxide diffusing capacity and it's low, this will automatically indicate that it's a diffusion problem because we just calculated diffusion capacity and it's low. So there's a problem in diffusion. If it's normal, it will be a VQ mismatch. Okay? Is that clear? Okay. But I just want to explain something that the doctor explained in your lecture today, and some of you might find it confusing. Okay. Now, if we give, let's go back to when we have normal carbon dioxide here. Okay. So it gives us a differential of we limit it down to either VQ mismatch, right to left shunt, and diffusion problems, and we gave 100% oxygen. Okay. And the partial pressure increased, okay? If we give 100% oxygen and the arterial partial pressure of oxygen increases to about 660, it can either be VQ mismatch or a diffusion problem, okay? Now, why did I say 660? And the doctor mentioned 660 in class, and this might be a bit confusing for you guys. So where do we get 660 from, okay? Let's recall from your previous lectures. You guys should know this from previous lectures, okay? But I'm just gonna recap it fast. The partial pressure of alveolar oxygen, okay, you guys can calculate it by the partial pressure of inspired air minus partial pressure of carbon dioxide divided by R, okay? That's the equation, okay? Now, what does partial pressure of inspired oxygen equal to? It equals to the fraction of oxygen in the air, okay, times the PB minus the P of the H2O, okay, water. This is not you don't need to focus on that. Yes, thank you so much for writing the equation. It's so much easier for me. I was just gonna type it. Okay, this is the equation, okay? This is how you know the partial pressure of inspired air, okay? Now we know the fraction of oxygen in inspired air, right? What is it? The normal. Perfect. The normal is 0.21. But in the case where we give 100% oxygen, I'm not just breathing oxygen from the air. I'm giving the person only 100% oxygen, right? The fraction of oxygen will be 1, okay, because it's 100%. So when we plot in the equation, okay, it will be 1 times 760 minus 47, okay, because these values are constant. The BP and the pH2O, okay, they're constant, okay? They're 760 and minus 47, okay? 760 minus 47 is 713, so you can approximate it to 710, okay? 710 times 1, exactly, the partial pressure of inspired air will be 713. And why do we calculate the partial pressure in the of inspired air in the first place? Because we want to know, or we want to compare it to the partial pressure of alveolar partial pressure of oxygen in the alveoli, okay? Why do we need to know the partial pressure of oxygen in the alveoli? Do you guys know? Perfect, because that's the limit for partial pressure of oxygen. Do you guys remember when we said the partial pressure of oxygen needs to reach the value of partial pressure of the alveoli for it to not count as hypoxia. If it doesn't reach, it will be considered hypoxia. Now, that's why we need to know the partial pressure of the alveoli, okay? So we got the partial pressure of inspired air to be 713, and we plot it in the equation for partial pressure of alveoli, okay? So we now get 713 minus the partial pressure of carbon dioxide, which is what? Do you guys know the partial pressure of carbon dioxide? 40, yes. 40 divided by 1. Okay, so 713 minus 40 will give us what? Approximately 660. This is where we get 660 from. Okay, this is why we use 660 as a value of comparison for the increase in the partial pressure of oxygen in the arteries. Okay, because if the partial pressure of oxygen in the arteries, like we just said, we gave the patient oxygen and the partial pressure increases. If it increases to 660 or approximately 660, we know that the issue is either VQ mismatch or diffusion limitation or diffusion problem. Okay. And how do we know this? Because in right to left shunt, okay, yes, the partial pressure when we give oxygen, yes, the partial pressure in here it will increase. However, it will not increase to 660 because we don't even have oxygen in our arteries and right to left shunt, right? It will increase to about 400. And that's why, if you guys remember, your Dr. Shams said 400 in the lecture. Because I am infusing the person with oxygen. They are getting oxygen. However, the oxygen is not high enough to reach the 660 value. Okay, if it's not large enough to reach the 660 value, it's automatically right to left shunt. Okay, that's why here we said partial pressure of oxygen does not increase with oxygen, with 100% oxygen. What this means is that yes, it increases, but it does not increase high enough. So overall, there is no increase. Okay. And when there is an increase, we automatically know it's right to left shunt. However, if it reaches 660, which is in the cases of VQ mismatch and diffusion limitation, now we know it's either VQ mismatch or diffusion limitation. And how do we differentiate between them? By using carbon monoxide diffusion capacity ratio. Exactly. Okay. If the diffusing capacity of carbon dioxide is normal, we automatically know that it's VQ mismatch, okay? However, if it's decreased, if it's lower than normal, okay, we automatically know that the diffusion isn't happening, so it's diffusion problem. Is that clear? Please tell me it's clear, because this is very important. If you guys don't understand anything on here, write it in the chat, because this slide is like literally a summary of all the 5 causes of hypoxemia, and this is what you need to focus on. Okay. Now, the last thing that your doctor mentioned, Dr. Shams, okay, he mentioned that when we infuse patients with oxygen, we need to be careful. Why do we need to be careful? We need to infuse them, like a person is hypoxemic. Obviously, what we're going to do is we're going to infuse them with oxygen. However, we cannot infuse them with oxygen where the saturation of oxygen is higher than 95, I believe, or 98. I'm not sure. The value isn't important. Okay, but we cannot infuse them with oxygen too much. Why? Because this is when it will cause problems. Exactly, because hypoxia itself is a drive for ventilation. If we give the person too much oxygen, the lungs will stop working. Okay, and the patient will be dependent on a ventilator. Okay. Why? Because hypoxia or increase in carbon dioxide, if we have increased carbon dioxide, it will be a stimulant, or like it will be stimulant for ventilation. Why? Because if we have carbon dioxide, we want to breathe. When we want to take it out, we want to exhale it. So this will stimulate the breathing. You know? Okay. This is why we cannot diffuse the person too much, because if we diffuse the person too much, خلاص يعني the lungs will stop working because they already have oxygen. They have enough oxygen. They're not gonna work too hard to try to bring in oxygen. Okay? Could I repeat? Do you want me to repeat the last part? The part with the oxygen? Why we don't give too much oxygen? Okay, I'll repeat it now. Do we use this formula to tell what exactly our problem is? This formula is for you guys to, you don't necessarily need to use this formula, the one that I mentioned here, okay? But the doctor, and to be honest, I'm not sure if the doctor wants you to use the formula ولا لا, because he didn't mention it in class, but the formula does help you into like distinguishing, okay? But you don't, I'm, to be honest, this formula was taught in the last class, so I'm not sure if you need to use it as Dr. Shams, okay? It depends on the kind of questions he's going to give you. Is he going to give you like straight up questions? Well, does he want you to calculate? Go back to Dr. Shams, because this wasn't the part of the lecture. Like, it was another lecture. Okay, formula links another lesson. Yeah, exactly. The formula links another lesson to this one. So ask Dr. Shams. But I'm sure that he told you to memorize this formula. Did he tell you guys to memorize this formula in the previous lecture? Yeah, then you guys have to memorize this formula, okay? Now, one of you guys asked me to repeat the last part on why we don't give too much oxygen. Okay, الحين, what drives our body to breathe? Okay, when we breathe and we take in oxygen, doesn't carbon dioxide in our body stimulate us to breathe? Because it will, if we have carbon dioxide in our body, we will want to exhale it out. So this stimulates us to take more oxygen in our body to exhale the carbon dioxide out, right? So carbon dioxide in our body is a stimulant for breathing. Correct. Okay. Now, if we put the patient on a ventilator, okay, and they're getting oxygen, and they're getting so much oxygen that they don't need to rely on their own body to breathe, their lungs will خلاص it will kind of die out. Okay, their lungs will not need to function. Why? Because why would my lungs want to work if the ventilator is doing the work for them? Do you understand the concept? This is why we don't give too much oxygen, because we don't want the person to depend on a ventilator. We want the body to still, we want to maintain the lung function. Is that clear? Okay, perfect. I think this is, let me check. Okay, yeah. So this was the last part. Thank you. Now we will we'll have a checkpoint. So far from everything, is everything clear so far? Perfect. Do you guys have any question? Here, feel free to unmute yourself and ask any question. Okay. I'm guessing that everything is clear. Okay. Now it's time for our practice questions. Do you guys want a break, or do you guys want to go ahead with our practice questions? Our practice questions aren't going to be long. So what do you guys want? No break, please? Okay, perfect. Okay. So our first question is, let me read it out for you. A 16-year-old girl is found unconscious on the street. She has no visible injuries and is taking shallow breaths of 6 to 8 breaths per minute. An arterial blood gas shows a partial pressure of oxygen of 55 milliliter of mercury, and her partial pressure of carbon dioxide is 75. The cause of hypoxemia is A, either low VQ ratio, B, intrapulmonary shunt, C, increased dead space ventilation, D, hypoventilation, E, elevated VQ ratio. So you guys can write your answers in the chat, and this person wants you guys to DM them to me. You guys can feel free to DM them to me now. Okay, are you guys ready to discuss, for me to discuss the answer? Or do you guys want more time? Because I only got one reply so far. Okay. Okay. I got answers of D and A. The correct answer, however, is D. Okay, alveolar hypoventilation. Why is this the cause of hypoxemia? Okay, because here it shows that the patient's partial pressure of oxygen is 55. Okay, and what do we know? What should the normal partial pressure of oxygen be? An arterial partial pressure of oxygen. Yeah, 90, and 100 or 90, okay, because 90 should be the normal partial pressure of oxygen, okay, in the arteries. Okay, so we automatically know now that the oxygen levels are decreased, okay, and her carbon dioxide levels are high, right? Because what do we know for the normal arterial carbon dioxide levels? What should they be? 40, exactly. Here it's 75, okay? So this is, we have high oxygen and low carbon dioxide, okay? And it's another hint in the question is that the patient is taking shallow breaths of 6 to 8 beats of 6 to 8 breaths per minute. What is the normal respiratory rate? I didn't mention this in the lecture, but I don't know if you guys know this or not. The normal respiratory rate is 14 to 20. Okay, so for this patient to have 6 to 8, this indicates that the patient is already hypoventilating. Okay, but with this already gave you the answer. But in here, for further like clarification, they already mentioned that that the oxygen partial pressure is very low, and the carbon dioxide partial pressure is very high. And where does this show? In hypoventilation. Why? Because the patient is breathing less, showing this we already know this because of the shallow breaths, okay, breathing less, so they're taking in less taking less oxygen and exhaling less carbon dioxide. Okay, is this clear? Is it clear why the answer is D, hypoventilation? Okay, any questions on this, or do we move on? Okay. Okay, perfect. So by the way, I got this question from Guyton, chapter 39, I believe, question 8. You guys, I'll send this presentation to your BLC. Everything I said, I transcribed in the lecture for you guys under it, and all the resources I got for the questions, I added at the bottom of in the notes section. Okay, so everything I said is also transcribed in the notes section. Okay, so I recommend you guys to go over it. Okay. So question 2, I got this question from Ambas, clearly. Okay, a 2-year-old boy is brought to the physician because of coughing and difficulty breathing that started shortly after his mother found him in the living room playing with his older brother's toys. He appears anxious. Respirations are 33 breaths per minute, and pulse oximetry on room air shows an oxygen saturation of 88%. Physical examination shows nasal flaring and intercostal retractions. Auscultation of the lungs show a high-pitched inspiratory wheeze and absent breath sounds on the right side. There is there's no improvement in his oxygen saturation after applying a non-rebreather mask with 100% oxygen. Okay. Which of the following terms best describes the most likely underlying mechanism of this patient's hypoxemia? Okay, please send your answers to me on DM separately. I know this question might be a lot, but we will after you guys are ready to discuss this question, I will go over it with you guys literally piece by piece. Okay, are you guys ready to discuss this? Wala or more gonna send me their answers. I got 2 replies so far. Okay, so the right answer is E, right to left shunt. Okay, let's take this question piece by piece. Okay, first we have a 2-year-old boy. Okay? He came in because of coughing and difficulty breathing. And what's important here is that his mother found him playing with his older brother's toys, okay? And this indicates that, like, you can tell that he kind of like aspirated one of the toys, okay? His respiration or respiratory rate is 33, which you already know he's hyperventilating, okay? Also, he's anxious, okay? And it shows that the oxygen saturation is 88. And we know that he didn't necessarily, he aspirated something. He didn't swallow it. He breathed it in. This is respiratory, okay? Okay. Yeah. Okay. Oxygen saturation of 88. You're right. Okay, because I will take it like one by one. I'll tell you the major clue. Okay, I'm just telling you guys over the clues, all of them. Okay, 88 saturation rate. Okay, with hyperventilation meaning that the person isn't getting enough air. So state of hypoxemia or hypoxia. Okay, why? Because we know the oxygen saturation. What's the normal oxygen saturation? You guys know the normal oxygen saturation? Okay. About 100. The normal. Sorry, I just wanted to check like my information before I give it. The normal oxygen saturation is 95 to 100. Okay, 95 to 100. Okay, so 88 indicates that the oxygen saturation is low. Okay, so the patient doesn't have oxygen, doesn't have enough oxygen. Okay, obviously indicating hypoxia. Okay, and his respiratory rate is 33, indicating that he's in a hyperventilating state. Okay, yes. PO2 is low, okay? The patient is in a hyperventilated state because of 33 respiratory rates, okay? Indicating that he is trying to breathe more to try to regain his oxygen levels to normal, okay? Physical examination shows nasal flaring and intercostal retraction. Again, nasal flaring and intercostal retraction just like is another clue that the patient is like trying to breathe to regain his normal oxygen saturation, okay? Auscultation of the lung shows a high-pitched inspiratory wheeze and absent breath sounds on the right side, okay? This, again, is another clue for what caused this or for it to be like aspiration by the toy. This isn't in this lecture, okay? But this is because the right side of the lung, if you guys recall, you guys are in CVP, if you guys recall, if you guys ever took this, okay, in anatomy, the right side of the lung is the most common location anatomically for toys to be aspirated in when a child breathes. Do you guys know why? This isn't part of this lecture, but it's important because this is very important for CVP. Do you guys know why they mentioned the right side here? And because the right side is more common. Yes, because the right side bronchus is shorter than the left bronchus and it's wider. Okay, and it's more it's easier for toys and whatever, like coins, to get stuck there. Okay, this is why they mentioned here, they give you like, they're trying to like hint or give you clues. Okay, and with high pitched respiratory wheeze, you can know that there's like something obstructing. Okay, now this sentence is the most clue that you'll ever get related to this lecture. Okay, there is no improvement in his oxygen saturation after applying a non-breather mask with 100% oxygen. So what this is telling you, that after the patient is in hypoxemia, we already established that. When the patient was given 100% oxygen, there's no improvement. And there's only one cause where the patient has low oxygen and does not improve with 100% oxygen. What is this? This is right to left shunt. Do you guys recall from here? This line, okay? Right to left shunt, if we give them oxygen, there will not be a increase in partial pressure of oxygen, okay? And why is this? So the patient did not improve with 100% oxygen. Why is this? It's because, and we know from a right to left shunt, the venous blood goes automatically into the arterial blood, and it does not get oxygenated from the alveoli because it's like passes it. Okay? Yes, exactly. Knowing that it does not get better with 100% oxygen automatically eliminates VQ mismatch and diffusion problem. Okay? Now, is this question clear? And do we move on? Does anyone have any questions regarding this question? Okay, taking that as a no, and I'll move on. So, I wrote this question, simple and easy. Which one, this is basic recall, okay? Which one of these is not a cause of hypoxemia? Yes, straight to the point. You guys know the difference between hypoxia and hypoxemia. This is because anemic hypoxia is a type of hypoxia and not hypoxemia, if that makes sense. Okay, it's tissue hypoxia. Okay, that's just a recall question. Is everyone good with that? Okay, but first, I want you guys to tell me what are the 3 types of, no cheating please, what are the 3 types of tissue hypoxia? Stagnant, anemic, and histotoxic, exactly. What are the 5 types of hypoxemia? Like 3 of them are written here, so you guys just need to recall 2 to be honest. Perfect. Okay, so we have VQ mismatch, hypoventilation, diffusion limitation, low inspired partial pressure of oxygen, and right to left shunt. Perfect. Okay, so the next question is shunts and VQ mismatch cause a, again, I wrote this question. This is recall. I want you, like, this is basically a revision of what we did, okay? Shunts and VQ mismatch cause a decrease in oxygen partial pressure. Why does the carbon dioxide partial pressure remain the same and not increase? There are like 2 answers. Why does the carbon dioxide partial pressure remain the same? And like there's, okay, answer how you guys would like to answer it. Yes, we don't lose a lot in carbon partial pressure. Exactly. Carbon, exactly. You guys are very smart, mashallah. Okay. The answer I was looking for first is because here, I wrote it down. Let me just make sure of what I'm saying. Why isn't it from? How do I make it smaller? No, okay. Oh, okay. So the answer to the first question is shunting and VQ mismatch only affects oxygen and partial pressure and not carbon dioxide partial pressure. Okay. So we said 3 things. What are the 3 things that cause that only affect oxygen and not carbon dioxide? Yeah, 3 things. So shunting, and there are 2 other things. One of them is written here. Yes, okay. Shunting, VQ mismatch, and diffusion only affect the partial pressure of oxygen and not carbon dioxide partial pressure. Why? Because of the carbon dioxide steeper curve. Okay, and refer to slide 21 for just everything I explained before. Is that clear? Do I move on to the next question? Does anyone have a question regarding this? Okay, so I will move on to the next question. Which zone of the lung has a higher VQ ratio? Again, I wrote this as a simple recall. Perfect. 1, exactly. Type Y. This is the last question, so difference between V and Q is bigger there, exactly because recall that, yeah, exactly because of lower compliance and because gravity makes the perfusion lower, higher, yeah, and stretching, exactly. So you guys, this we discussed it before. Does anyone have any questions on this, on why it's 1? Is everything clear so far? Okay, perfect. This is the last question, and these are the resources I recommend and the ones I use to prepare. Other than Dr. Shams's slides, I recommend you guys to watch Boards and Beyonds. B&B stands for Boards and Beyonds, okay? Boards and Beyonds Hypoxia video and Boards and Beyonds 1. You guys have the resources file, right? Folder? Okay. So hypoxia, Boards and Beyonds, ventilation, perfusion, Boards and Beyond, osmosis, hypoxemia, and hypoxia. Osmosis, diffusion, only focus on diffusion limited gas exchange because that's the one we're focused on in class. And osmosis, ventilation, perfusion, and VQ mismatch. This video is really good. So I recommend you guys to look at over these resources, and I will. Do you guys want me to give a quick recap of what we discussed so far? Like a quick summary? Okay, I will do that. So let me in the presentation here. Okay, I will give a quick recap and then you guys can unmute yourselves, ask any questions, and I will answer the question about the anemic, what is it called? Anemic hypoxia that one of you guys asked me, okay? So feel free, by the way, to email me on this email, okay? If you guys are studying the lecture later, of course, no problem. If you guys are studying the lecture later, if you feel free to ask me anything on my email, or you can text me. I have WhatsApp on my number. It's here. So as a quick recap, first, we gave a recap of why oxygen was important. Then we discussed the difference between hypoxia and hypoxemia. We talked about the five causes of hypoxemia or arterial hypoxia, and the 3 causes of hypoxia or tissue hypoxia, and this is the 5 causes of hypoxemia are what's actually important for the lecture. We discussed them one by one. We talked about the low inspired oxygen, partial pressure of oxygen. We told you guys need to differentiate the low inspired oxygen between hypoventilation. We talked about the diffusion limitation and the difference and how the arterial partial pressure always needs to reach alveolar partial pressure for there not to be a hypoxemia. We then discussed hypoventilation and how this can cause hypoxemia. We talked about VQ mismatch, which is the bulk of this lecture, and this is what you need to majorly focus on. And I keep on forgetting the tissue hypoxemia. Do you want me to quickly recap tissue hypoxemia? Okay. See, by the way, I transcribed everything for you here. Okay. So stagnant hypoxia, okay, is an example of that is arterial stenosis. Okay. Arterial stenosis is narrowing of the artery. How does stagnant hypoxia or arterial stenosis cause hypoxia? Because if we have no narrowing of the artery, we'll have less blood supply. Okay, less blood supply, less oxygen delivery, hypoxia. Done. Anemic hypoxia. Okay. Oh, by the way, I have an answer to your question. I just remembered how dumb I am. Okay, you asked that in tissue hypoxia, or especially in anemic hypoxia, do we have low partial pressure of oxygen in the arteries? Right. That's your question, right? In hypoxia. I'll answer it by this way, but let me focus on the anemic hypoxia. Anemic hypoxia, from the name itself, the problem is with hemoglobin. Okay, hemoglobin is reduced, and when we know that hemoglobin is what carries our oxygen. So when we have reduced hemoglobin, we will have less oxygen delivery to the tissues, leading to hypoxia. Okay, as for histotoxic, we have enzymatic defects that decrease the production of decrease the production of ATP due to low oxygen, and this can cause hypoxia. Okay, for example, cyanide poisoning. Okay, these are the tissue hypoxia. Where did we get to? We got to hypoventilation. Let me make it bigger. Okay, we discussed, what is it? Yeah, we discussed the VQ ratios when there's high VQ ratio, normal and low. We also discussed, this slide is very, very important. We discussed VQ mismatch, okay? And I gave you an example on VQ mismatch. We discussed right to left shunt and alveolar dead space and how to differentiate between them. We discussed why VQ mismatch, shunting and diffusion limitation only affects oxygen, not carbon dioxide. It's because of the steep carbon dioxide curve. And then we discussed right to left shunt, and we discussed how to differentiate between all types of hypoxemia. And that is it. Do you guys have any questions? The one who asked me about this question, the decrease in partial pressure of oxygen, stay, because I'm going to answer it right now. You guys can stop the recording, and you guys can feel free to unmute yourself and ask me anything. And thank you so much for attending this session. Feel free to email me